So, positive pressure ventilation. This should be a review as well for most of us, but we are going to talk about some more advanced topics in terms of pressure ventilation. So, airway management and ventilation are closely related, but they're two totally separate components of patient care. What we have to remember in some patients, once the airway has been secured, ventilation will begin with no intervention whatsoever. However, some patients, we don't need to do any advanced airway management procedure. All we simply need to do is ventilate them. However, most of the time what we have to do is a combination of the two. We both have to ventilate them artificially and secure their airway. So negative pressure ventilation. We know about negative pressure ventilation. That's how we breathe. That's the flow of gas from an area of high concentration to an area of low, not concentration, excuse me. We're not talking about diffusion here, but we're talking about pressure. So an area of high pressure to low pressure. During normal ventilation, we have due to the contraction of the diaphragm and the expansion of the thoracic cavity, we have a negative pressure, a vacuum that's created that's going to draw air in. This negative pressure ventilations, when we do this, the average tidal volume for most patients is going to be about 7 milliliters per kilogram at rest. That's the number. When we talk about the chest moving air adequately, there's not enough airflow to effectively ventilate. When negative pressure ventilation is ineffective, positive pressure ventilation can be life-saving. And what do I mean by positive pressure ventilation?
BVM,
CPAP,
BVM, bag valve mask. All of these methods employ positive pressure ventilation, and that's what we're going to do. So instead of having that vacuum that's going to draw the air in, we're going to force the air in. Positive pressure ventilation requires that the airway and lungs are isolated from the external environment. And how do we isolate these guys from the environment?
create a seal.
Yeah, we create a seal with a mask. The mask is going to isolate them. So anytime the patient needs this ventilatory support, or patients that are hypoventilating or apneic, we're going to ventilate them. General rule of thumb that I follow is less than 8 over 30, we're going to ventilate them. So, positive pressure ventilation of the patients with unprotected airway requires an airtight seal to the patient's face. Now, it's important to remember, and we'll emphasize this in lab, is we're going to bring the face to the mask, not push the mask onto the face. And this takes lots and lots of practice. I can tell you, everybody in here is going to do a poor job at doing it. Every student does a poor job doing it. Most paramedics do a poor job with ventilation. But we're going to work on this. Like I've alluded to already, you guys are going to bag until you puke, because you're going to master the skill of ventilation. Because even if we have a small leak, we're going to actually have a drastic effect in ventilatory volume decrease. Positive pressure techniques at room air, the patient should be ventilated at approximately 10 mils per kilogram to produce adequate oxygen to support life. But the general rule that we follow for tidal volume is going to be what when we're ventilating a patient?
Chest rise.
Chest rise. We want to make sure that the patient has adequate chest rise. Now, can we ventilate patients on room air
Yes.
with a BVM?
Yes.
Yes, but as soon as we can, we want to get them on 100% oxygen. All right, and once we get them on 100% oxygen, we can decrease the tidal volume down to about 6 to 7 milliliters per kilogram. Why can we decrease the tidal volume at that point in time?
So being oxygenated more.
Yeah, we're giving them a higher concentration of oxygen, so we can decrease those volumes. And it's good to decrease those volumes because, again, we're going to prevent barotrauma. And we don't want to cause barotrauma, but that is the side effect and the complication that we possibly can have that positive pressure ventilation. So during the positive pressure ventilation, we'll get a dramatic rise in interpulmonary pressure that makes it necessary to overcome the weight of the chest wall and the elasticity of the chest muscles with each ventilation. So that's something that we've got to overcome and adapt to when we talk about the actual ventilation. The problem with this high pressure is, again, the complication of barotrauma. The other problem besides barotrauma that we have is we are going to have the possibility of having a decrease in cardiac output because we're increasing the pressure in the thoracic cavity. So when we talk about barotrauma, what are some complications that we can see with barotrauma? What are some problems when we ventilate patients that we worry about? Pneumothorax, okay, tension pneumothorax, obviously, a pneumomediastinum, or possibly a subacute emphysema. What's a pneumomediastinum? You're saying to yourself, man, this was on Final Jeopardy last night.
Nobody watches Jeopardy. Not since Ken Jennings won for 3 months in a row.
Air in the mediastinum.
Air in the mediastinum. The mediastinum is the area where the heart lies. Okay, but these are all complications you get from positive pressure ventilation.
Will that not be a tension pneumo? If it's a pneumomediastinum, is that not a tension
It
pneumo?
could be but what if it's the air is only in the mediastinum? Because the mediastinum is separated from the actual pleural space. It's a good question. And,
I don't get how it happens without something alluding to that.
it starts out as a pneumomediastinum, and it's going to progress. And if it causes tension, then it's going to become a tension pneumothorax.
Well, okay. How does it get there first off? Where is it coming from to get there?
Where's it coming from?
Is there a pneumothorax already?
Some type of breach in the tracheal tree, right there at the mediastinum area, before it inserts actually into the right main stem or left main stem, and then air is leaking out into the mediastinum space. So if you get something right in this area and it's going down, not a very common occurrence that we're going to see, but that's a possibility. So
Can you diagnose that?
can you diagnose that? No, we're not going to diagnose that. The way we may diagnose that, we may see it as it may appear as a pericardial tamponade to us because it's going to affect the cardiac output. So you may see the signs of a Beck's triad. So positive pressure ventilation, when are we going to do it? Apneic patients, patients that are hypoventilating, contraindications, conscious patients with adequate air. Now, can we ventilate conscious patients? Yes, we can. And that's something that we've got to work on in the sense that patients that we ventilate that are conscious, we have to work with them and not against them. And all too oftentimes we sit there and we ventilate them and say, you're going to breathe when I tell you to breathe. But what we really need to learn how to do is adjust it. When the patient takes a breath in, we augment their breath in. And when the patient exhales, we allow them to exhale. We've got to work with them in that sense. So positive pressure ventilation is dramatically different than normal breathing. And we have to remember that. It's not normal. To the body, it's a totally foreign concept and foreign idea. So there's things we have to think about when we deal with this. So the flow of gas through a tube is laminar or turbulent. All right, and that's why we don't want to forcefully ventilate patients, because turbulent airflow. Laminar airflow means everything's going in a nice straight line. When we talk about turbulent airflow means that air is moving around in a circle. Think about turbulence on an airplane. Would you rather have laminar airflow and have a nice smooth flight, or would you like turbulent airflow where you're bouncing all over the place? All right. So laminar flow, the gas moves in a relatively straight line, and in turbulent flow, they bounce into each other and into a circular manner, which causes problems. Laminar flow is efficient. Turbulent flow wastes energy. So again, what we want to make sure that we're doing is we're ventilating it at an appropriate rate and an appropriate volume, and not too forcefully. We don't want to force that air in. We want to. That's what we emphasize when we talk about the rule of twos, 2 psi's, just very gently squeezing that bag, not sitting there squeezing that bag like it's a squishy stress ball. All right. At slow flow rates, gas molecules move at a relatively straight line with few disruptions. But again, as we increase the forcefulness of our ventilations, we're going to cause that turbulent airflow. And that turbulent airflow, again, is just a waste of energy and a waste of space. So we do everything that we can to strive to keep that nice, straight, not turbulent airflow to decrease the proportion of gas reaching the alveolar capillary interface. Again, doing your part to decrease that. So what we want to try to do is decrease that flow rate to less than 60. Less than 60 is the ideal way, and we achieve that by doing our volume in over 1.5 to 2 seconds. So 2 psi in about 2 seconds. So when we inhale, 1, 2, at a nice slow rate. Again, we'll practice this in lab. There you can see on this diagram, you can see nice smooth airflow, nice straight line, and then you can see turbulent airflow, how it's bouncing back and going all over the place. Again, it's not going to be efficient to deliver that air and that oxygen down into the actual alveolar space for the gas exchange to take. The other thing that we have to consider besides that is the hemodynamic stability of the patient. So we talk about normal breathing. Negative pressure with each breath causes the venous return, increases rather the venous return to the heart. So that intrathoracic pressure sucks because we got negative pressure there, so it still creates a vacuum even for blood. It's going to suck that blood back into the chest from the head and the abdomen. The thing we have to remember, venous return. Does the vein have a pump? Venous system doesn't have a pump, so we got to have something to augment that. When we move patients to positive pressure, we lose that negative pressure that's going to suck that blood in. Besides the fact that we are increasing interthoracic pressure, which also causes stress on the heart or pressure on the heart, which is going to decrease cardiac output. So we have a twofold factor here that's decreasing our cardiac output to our patient, which is going to cause hemodynamic instability or a drop in blood pressure. So increased interthoracic pressure, the greater the pressure we use to ventilate an apneic or hypoventilating patient, the greater the decrease in preload and increase in afterload. And therefore, the greater the possible resulting decrease in cardiac output. Okay? Normal cardiac output for a person is how much? About 5 to 6 liters a minute. We decrease this to maybe 3, 4 liters per minute by positive pressure. And again, these are not scientific numbers that I'm throwing out here, but just to kind of demonstrate to you what the drop is. So if we drop that cardiac output, okay, yes, we dropped the blood pressure, but besides dropping the blood pressure, with that drop in blood pressure, what else have we lost? The ability to deliver what? Oxygen. Deliver oxygen and pick up carbon dioxide. So patients who are hypotensive or in shock or hemodynamically unstable may experience profound changes in blood pressure as a result of that hemodynamic effort. So distension of soft tissues, positive pressure ventilation pushes air into the lungs, and the entire upper airway must have higher pressure than the pressure at the capillary alveolar membrane. So what this means is increasing the pressure causes the patient's cheeks to puff out and the entire upper airway to distend with each breath. Think about this. So we're forcing that air in. It's not passively going in. We sealed it all off. So air is always going to follow the path of least resistance. What's easier to do? Go down the trachea, or to just stay here and just puff the cheeks out?
Go down.
Puff the cheeks out. It's coming down here. What else does it want to do? It wants to expand out in the trachea, and again it wants to go in because there's nothing drawing it in. We are forcing it down. You follow the concept that I'm saying here? So what we're doing is when we're ventilating these patients, we're not going to get the most efficient delivery of gas down to the alveoli as if we're breathing on our own. What we're going to see in these patients is we're going to deliver a less than ideal percentage of gas, or not a percentage of gas, but pressure that's going to make it to that alveoli. So gas exchange is not going to take place as efficiently as it would in a patient that's normally breathing like you and I are right now. Okay? That makes sense? Okay. So the distension of the airway and the tissues results in a large airspace that needs to be filled. So normal relaxed pressure in the tidal volume is approximately 6 to 7 mils per kilogram. To maintain deep lung ventilation, and either the tidal volume must be increased or the oxygen concentration increased. So what do you think is better to do? Increase the tidal volume or increase the oxygen? Yeah, realistically, increasing the oxygen will get that there, because why do we not really want to increase the tidal volume too much?
Barotrauma.
We don't want to cause barotrauma. However, we still want to make sure that we're getting adequate ventilation volumes, so that way we're causing CO2 to be offloaded and we're holding on to that CO2. So we want to deliver about 10 mils per kilogram when we're ventilating someone. All right, and as soon as possible, we put them on 100% oxygen and get them at 6 to 7 mils per kilogram. So we're going to ventilate a little bit deeper, a little bit more volume if they're not on oxygen. Once we get them on oxygen, we can cut back that tidal volume. Does that make sense? Okay. So things that we don't want to get is gastric distension. All right, realize it only takes about 2 millimeters of pressure to break the cardiac sphincter, okay? And that cardiac sphincter, when we talk about the cardiac sphincter, that is what opens up at the base of our esophagus to go into our stomach, all right? Which is bigger, our trachea or our esophagus?
Esophagus.
Esophagus is bigger, so air wants to follow the path of least resistance. It's going to get less resistance in the esophagus. So air would much rather travel down that. And if we break open that cardiac sphincter, all that air is going to go into the lung or into the stomach. We see this. Patients that have been ventilated for 5-10 minutes prior to us getting there. And we show up and the patient's got a big old abdomen. Patients like Jacob's size normally, and then you show up on scene and they're my size. All right, because we forced all that air into their stomach. All right, so we got this distension. The problem with gastric distension, besides the fact that they're potentially going to vomit all over us and erupt like a volcano, is the fact that all that gastric distension is also putting stress on the thoracic cavity, which in and of itself is decreasing cardiac output. All right. So again, gastric distension interferes with the ventilation, and not only does it interfere with ventilation, it's going to interfere with actual cardiac output. So the amount of air that goes into the stomach depends on the esophageal opening pressure and the pressure of the gas in the upper airway. And we can see in this graph here, we can see time and where the gas is going to go. With proper ventilation at a lower pressure, we don't break open that esophageal opening or that cardiac sphincter. But in poor ventilation that's got a high volume and high rate, we see that we break open that sphincter, and all of that gas is going to go down into the actual stomach and cause that gas distension. So the esophageal opening pressure is the pressure required to force it through the flaccid tube. It only takes about 25 centimeters of H2O to open that bad boy up and allow that air to go through, which equates to, again, like I alluded to earlier. If the patient remains unconscious, it can slow us to 0 to 5 centimeters of water in cardiac arrest. So 0 to 5 centimeters of H2O means that it's not going to take anything to actually open up that cardiac sphincter. So when the gas enters that upper airway, it exceeds that esophageal opening. Again, like I said, gas is going to cause the opening of that cardiac sphincter, and all of it's going to go down into the gastric space. And again, now we have all this air in the stomach, which is going to lead to the patient puking and also increasing that cardiac output. So we want to do everything that we can to prevent this, and that's why we talk about cricoid pressure and the reduction of pressure and ventilations and the length of time that we actually ventilate. So, lots.
How do you bag a patient that the sphincter's open? I mean, if it's 0 centimeters of water, that's just going to be open.
Mm-hmm. You're going to ventilate them, and that's why we're going to talk about using like cricoid pressure or something in those lines to prevent them from actually getting that gas into the stomach. And that's really the only way you can prevent it without having an endotracheal tube or some other type of airway device in.
So you just force the esophagus closed.
Right, we pinch it closed by doing the cricoid pressure.
Okay.
All right. So reducing gastric distension is to lower the esophageal opening pressure as best as we can and prevent the air from actually getting there and making that esophageal opening. So we've already talked about maintaining a low pressure, maintaining or increasing our length of ventilation or inspiratory time, and again, keeping our inspiratory pressure as low as possible, keeping it somewhere around 15 centimeters of H2O. And again, this takes lots and lots of practice. This is not something that's going to come to you overnight. So assume when opening pressure is not constant, alcohol, drugs, food, diseases are going to jack with your esophageal opening pressure. So if you've got any patient in there, we've got issues with that. I also want you to think about patients that, or I want you to all think back about a time in your life when you've been drunk. Some of you, that's been more recent than others. When we have those issues at hand, how many of you have woken up at 2 or 3 hours after the drunk and aspirating, running through the house, looking for something to stop the aspiration? And that's because your esophageal opening pressure has decreased greatly, and it's opened up, and all the stuff that you had in your stomach is now up and saying hello to you and trying to go down your trachea. But in cardiac arrest, esophageal pressure is going to be lower too. It's really not going to be possible to ventilate a patient who has been intubated without exceeding esophageal opening pressure, and that's important to remember. So posterior cricoid pressure, cricoid pressure is not really talked about in current AHA guidelines. However, cricoid pressure is still a valid tool for us to use, but it's got to be done correctly and it's got to be done right. Because if you don't do it right, it's not going to cause you any benefit. It's only going to cause you problems. So the posterior cricoid pressure is going to reduce the amount of air that makes it down to the stomach. And we also sometimes call this the Tom Selleck maneuver or just the Selleck maneuver. So because the esophagus lies in between the trachea and in between the vertebrae, by putting that pressure on the cricoid cartilage and pushing back, we are actually able to pinch off the esophagus, preventing any air from going there. How do we keep the trachea from collapsing when we put that pressure?
What do they call it? When you push to the left and up?
Oh, you're talking about burping, and we'll talk about burping a little bit later. But it's the cartilage rings. The cartilage rings are going to prevent you when you push back on that cricoid membrane or cricoid right there. You're going to prevent. You're not going to be able to actually collapse down that trachea. You're just going to put that pressure, which is going to push back and go on to the esophagus. So pressure applied to the anterior portion of the ring is transmitted to the posterior portion, and this includes the esophagus by pinching it between two hard objects, thus reducing the amount of air that sneaks through and gets into the stomach. In addition to decreasing the volume and air entering the stomach during positive pressure ventilation, it also, for all of that air that's already trapped into the stomach, is going to help prevent it from erupting and coming out and spewing on us like Mount St. Helens. All right? Because we all know that if you start puking, everybody else in the back of the truck's going to start puking too, and a whole lot of patient care doesn't get done that way when everybody's puking all over the place. So once you start cricoid pressure, you really, until you get the airway secured, really shouldn't release it, because again, once you release it at that point in time, typically speaking, that is when Mount St. Helens is going to erupt. If a patient is already regurgitating, don't put cricoid pressure on to stop the regurgitation. Let them go ahead and get all those contents out, because otherwise you might cause a esophageal rupture, Mallory-Weiss tear, something in those lines, which is going to cause even more complications and problems for the patient. And don't apply too much force. Don't cause a laryngeal fracture, which is also known as strangulation. Okay, you don't want to cause that to happen. Otherwise, you might be known as a serial killer at that point in time, and the FBI or some other law enforcement agency may be hunting you down for doing your job because you were actually strangling patients. All right, that's my dry humor for the evening. So, Selig maneuver, visualize the cricoid cartilage, palpate to confirm its location, and apply that firm pressure to the cricoid with your thumb and index finger on each side. And again, you've got to put some force to put it back. You're not going to be able to do it on yourself because you're not going to be willing to put enough force on there. It's uncomfortable. Your partner's probably not going to let you do it to them either. But again, it's something that you need to practice and again, work on. Because most of us, when we do cricoid pressure, we don't put enough force back behind there to actually cause the actual closure of that of the esophagus. So you can see some diagrams there. Step 1. Again, what do we notice in this patient's airway? Besides the fact that they're doing things to do cricoid pressure.
They extended.
He's got his airway's open. Somebody manually opened his airway. Again, you've got to remember to do that. You've got to manually remember to manually open that airway. So again, use the Tom Selleck maneuver to decrease gastric distension and passive regurgitation. Right? So that is Selleck maneuver. So now we talked about ways of preventing gastric distension. Well, what if the gastric distension is already there?
Push the stomach down.
Huh?
Relieve the stomach.
Okay, relieve. Yeah, we got to relieve it. So we got to remove the air and the contents from the stomach, which is gastric decompression. We can either do it invasively or non-invasively. So invasive gastric decompression is putting something like an NG tube or an orogastric tube into the stomach and then sucking out the contents. It can either be inserted through the nose, which is a nasogastric tube, or through the mouth, which is an orogastric tube. Realize in New Mexico, you cannot do an orogastric tube. You can only do a nasogastric tube. However, you will learn how to do both. And yes, to answer all of your long, burning questions, you will be doing NG tubes on each other in lab. For those of you that are coming to visit us, that are watching this lecture, we will be doing NG tubes when you are here for Skills Week. For those of you that are in the traditional in-seat class, we will be doing NG tubes week 2.
Why don't they allow us to do both? Or why don't they just...
It is the way it is written into the scope, because there's too much margin for error, in their opinion, when you use an orogastric tube. When you use the nasogastric tube, it goes in more precisely, is their argument.
But they let us do a ET tube, so...
Exactly. Exactly. So NG tube is a long tube inserted through the nose, into the nasopharynx, and through the esophagus, and into the stomach. All right. All patients that are intubated, remember this, all patients that are intubated should have an NG tube put into them. You should go ahead and cut and reduce the stomach contents and get that out of there. Again, number one, we want to make sure that we have the most precise and best cardiac output that we can possibly have. And the other thing is it helps reduce the stress that's there. So for the purposes of airway management, the tube is used to decompress the stomach, thereby decreasing pressure on the diaphragm and limiting the risk of regurgitation. During the insertion of the NG tube, many patients are going to be awake, will gag, and may even vomit. Realize it is much easier to put an NG tube into a patient that's conscious than a patient that is unconscious. Okay, because when they're conscious, they can actually help you. Yes, it is uncomfortable. I'm not going to lie, it is an uncomfortable procedure. And it remains uncomfortable even when the tube is in there. But it is not the worst pain that anybody is going to feel by all means. All right. So insertion of the NG tube in patients with severe facial injuries is contraindicated. If they got a broken nose, obviously you can't do it. If they've got possibly a Lafort fracture or they got a basilar skull fracture, definitely going to not want to do that because, again, you could run the risk of actually implanting this NG tube into the brain. Granted, it is a very low probability, but again, you want to always weigh the risk with the benefit. All right. So we put NG tubes in to reduce the threat of aspiration and to decrease the pressure on the stomach. Be careful with esophageal disease, like patients that have esophageal varices. What is an esophageal varices?
Blisters on the throat, right? Caused by too much drinking.
It's not blisters on the throat. What it is it's, you know what a hemorrhoid is? All right, hemorrhoid is a blood vessel that's at the cervix around the anus. All right. Well, when we talk about varices, it's blood vessels that are there, right at the surrounding the esophagus. So when we insert something like this in there, we have the risk of actually perforating one of those varices, causing them to bleed. It's a portal vessel, which means it's coming from the liver, which means it's got a rich vascular supply. You're after one of those bad boys, there's going to be blood everywhere. You're talking to somebody that knows this by experience, okay? So you want to really use caution if you're putting this into somebody that has a esophageal varices.
How did you know that you ruptured it? Did blood come back up? Or?
Blood was everywhere. Blood was coming out all over the place. It was just bloody. Granted, I didn't cause any further harm to the patient, but that was the issue that we had. So, in a nasogastric tube insertion, explain the procedure to the patient. Always let them know what you're going to do. You can suppress the gag reflex with a topical anesthetic, like some viscous lidocaine. Always should use some viscous lidocaine on that. A lot of people will use the viscous lidocaine as a lubricant. If you're using it as a lubricant, it's not having time to work. You kind of got to use it a little bit before, and then go ahead and use it as a lubricant as well. The other thing, too, is you should go ahead and use some neosynephrine. Go and squirt that up the nose. Let it go ahead and start to cause some constriction of those vessels, so that way they don't bleed like a stuck pig. Then you're going to measure it for the correct depth of insertion. You measure from the nose to the ear and then down to the xiphoid process. All right? And that's how long you're going to insert it. You're going to mark the tube there. Either mark it with your finger or mark it with a piece of tape, but that way you know not to insert it any further than that. Because you don't want to keep shoving the tube down in there and just let it start rolling up and rolling it up like a water hose in their stomach. All right? So there you can see step one, step two. See, in this case, in this picture, they're using some hurricane spray. Hurricane spray is awesome to utilize. It's an anesthetic for that. You can see I'm measuring the tube out. Then you're going to lubricate. You're going to advance the tube gently along the nasal floor and encourage the patient to swallow or drink to facilitate passage of the tube. Obviously, in the ambulance, we don't have something for them to drink, but you want to encourage them to swallow, especially when you get down to that point, because swallowing is going to ensure that it's going down the right tube, and besides encouraging to make sure it goes down the right tube, the other thing that swallowing is going to do is it's going to facilitate the passage of that tube down. All right, so we want to utilize that. So you can see lubing it up, and you can see that they have the head down a little bit, and then they're inserting the tube there. Okay, You're going to advance the tube into the stomach. You're going to confirm placement. You're going to auscultate right over the epigastric region with about 50 cc's of air in a syringe. You're going to push that in through the end, and you're going to listen for that air bubble and gurgling, and that's when you know. If you hear that, you know you're in the stomach. Okay. Then you're going to apply some gentle suction. We want to have them on low intermittent suctioning. We don't want to have them on high constant suctioning, because high pressure is going to obviously suck onto the lining of that stomach, and the constant is going to sit there, and it's going to constantly sit there and suck and start actually ripping off the stomach mucosa, which is going to cause ulcers and other problems for us. So that's why we want them on low intermittent suctioning. So you can see them actually starting the tube there, going up through, and verifying placement. The other option is the OG tube, and it's the same thing, except instead of going through the nose, it's actually inserted through the mouth. Lower risk of nosebleeds when we use this, and again, it's an increased safety in patients that have severe facial trauma. It is less comfortable. It causes gagging, so obviously we can't really do it on a conscious patient. So it is the preferred method for an unconscious patient that doesn't have a gag reflex. There you can see the indications: threat of aspiration to decrease the pressure on the stomach in an unconscious patients. Okay. You can use larger tubes, and oftentimes this is what they'll actually use. Well, not oftentimes, it is what they use when we talk about gastric lavage. Somebody that's maybe overdosed or something like that, actually washing out the inside of the stomach. So oral gastric tube is going to be about the same. Position the patient's head in the flex position. Measure the tube for the correct insertion depth, nose to ear, and then the xiphoid process. Lubricate the tube. No
61.
No reflux around the tube, meaning that there should not be any secretions, anything like that around the tube itself.
So it's got to come straight out the tube, not around it.
Right.
It does come out from beside it.
You're going to be kind of concerned about that, because that means you're not actually going to be able to secure the airway with that. Because you're not securing the airway, but what I mean is you're going to run the risk of the patient actually vomiting, and all that stuff's going to come up and actually go down the trachea.
Does that mean you have it misplaced, too far, not far enough, or it's just they've got too much stomach contents?
Too much stomach contents. And you're going to have to do something to actively suction out and get everything out. So which means you may have to suction them out just to get all that contents out, and you may have to consider using just your regular traditional oral suctioning to get all that stuff out. It's only going to be a problem for a little bit of time, and then everything should go back to normal. And this is another reason why we really don't do oral tubes as much as we do nasal tubes.
So would you take your tube out and then reinsert it, or leave it and suction around it?
Leave it and suction around it. You're going to just do your traditional oral suctioning, and in addition to doing your oral suctioning, you may go ahead and suction instead of on an intermittent suction initially. You may have them on a constant suction just to try to evacuate all the stomach contents into there. You just want to make sure that you don't leave it on a constant suction so it doesn't start ripping up and tearing off all the stomach mucosa. So there you can measure it down, going in, actually placing it, and verify your placement. We do have non-invasive gastric decompression, which will allow you to decompress the stomach quickly. May occur with life-threatening gastric distension, and it's more common in children than it is in adults. So what you will do is you'll actually apply epigastric pressure, which will force the air out. But the problem with that is it's also going to cause food, liquids, everything else that's in the stomach to come out as well. So obviously, because you don't have a tube in there suctioning it out, you run the risk of aspiration. So why you would do this is it's severe gastric detention that's interfering with ventilation. You don't have gastric suctioning available to you. Again, it's non-invasive, it's quick. There's a large risk of aspiration, that's why we don't do it. So you want to get your suction canister ready, your suction tubing, put the patient on their left side. You're going to slowly apply pressure to the epigastric region until you start to actually get all that air to actually come out. Same rule applies here. We're only going to take a little bit of pressure, about 25 centimeters of water, to break that cardiac sphincter. So we start putting some pressure on that, we're actually going to cause to open up, would allow that air to come out. But again, when the air comes out, so is food and other contents, and it's going to go all over the place. So there you can see how to manually decompress the stomach.